Hello and welcome. We're really excited to have you here today at our quarterly provider collaborative webinar to talk about citizenship waived medical, also known as CWM, and to share some program updates that have been in the works that we're really excited about. We have quite a few things to go over today, but we also really want to make sure we have plenty of time for questions and answers. Here's an outline of where we're going to be in the next hour plus change. Going to do a few introductions to some of our staff, do a quick review of what citizenship waived medical is, talk about some of those changes, some of the exciting ones being additional services to bill for end-stage renal disease, behavioral health crisis, cancer coverage, and with these new additions, additionally some new pharmacy coverage for CWM. Going to talk a little bit about how we define an emergency and some changes that are happening with that definition. And we're going to talk about the responsibility for providers and members to share when something is not a covered service. And so you might know that as Form 3165 or maybe 3166 in the case of pharmacy. And so we're going to talk a little bit about all of these things. I'm going to talk very briefly about Healthier Oregon, but that is not the focus today. And then we're going to have time to listen and talk about what this all is bringing up for you and where you might have more questions or want to learn more. This is definitely the beginning of a conversation. So there's a lot of things in this world that are rapidly evolving. We're sharing the state as of June 17th, and we'll continue to get updates to you as we continue to get, maybe it's going to be a systems change or further rule change or additional context or information based on what we hear from you today. With that said, I'm going to transition us into our formal introductions. I will go first. My name is Jessica Diaz, and I work on the Community Partner Outreach Program team here at the Oregon Health Authority. My position is the Provider Outreach and Engagement Strategist, and that is a statewide position serving all of the lovely Medicaid providers out there and in our community partner network, as well as working with folks who maybe want to learn more or get additional resources for working with providers. And I'm going to hand it over to Courtney to introduce herself next.
Thank you, Jessica. Good morning. My name is Courtney Seavey. I work with the Medicaid Programs Unit, and I am the new Citizenship Waived Medical Program Analyst, and I'm happy to be here today.
Thank you. We also have a few other folks at OHA who are sort of quietly on call to help us out, and so they will introduce themselves if and when the time comes when they want to offer additional resources or context for us. And if you'd like, I'd welcome anyone to put in your name, position, and where you're coming from in the question box as well to give our staff a feel for who's in the audience. And while you all do that, I'm going to do an extremely brief overview of citizenship waived medical. So CWM is a type of Medicaid benefit, and it's for adults living in Oregon who do not have a qualifying citizenship or non-citizen status to get the full OHP benefit package. And it historically has covered emergency services and then sort of a smattering of additional things as we write them into law and as we are able to provide them. Now, we have switched this year to using CWM as our acronym, not CAWEM. And that is because there's some words in that obsolete acronym that are alienating. And we are trying very hard to move over to more neutral language. And it's more accurate language as well, especially as we continue to evolve what this package is. I do want to clarify that today we're going to be talking about CWM much more than we're going to be talking about CWM Plus or any of the other sort of related programs. So we're not going to talk about Cover All Kids. I have, I think, exactly one slide about Healthier Oregon. we're going to be focusing on the emergency coverage of CWM. I do want to acknowledge CWM Plus is a very important program that is part of the CWM suite and includes full OHP benefits during a pregnancy and for 2 months after a pregnancy ends. Because that program is not undergoing any changes at this time, we're going to focus our time and effort on CWM, the emergency medical side of things. And as a note, we are working to get our acronyms all in line, but we're a large agency. In fact, we're multiple agencies if you bring in the ODHS systems. And so it is taking some time to update all of those acronyms everywhere we have it. And I know that in the provider portal in MMIS, it does still show up with that obsolete acronym, but expect changes in the future. So now I did mention this in our objectives, but I do want to reiterate what we're focusing on today. And we're going to spend most of our time talking about some changes that started January 1, 2022. So that's when these changes went into rule. That is adding end-stage renal disease coverage, behavioral health crisis, and cancer. These system updates, so there's the rule side of things and there's the system side of things. And the system updates, many of these are still in progress. So we are still working on MMIS updates and other things to help make this a more straightforward process that goes through successfully when a provider bills. There's a lot of moving parts that Courtney can speak to better than I can. And there's been a lot of really hard work going on, and you're going to see where we're at right now and where we're headed in the near future. And I'm not sure, Courtney, do you want me to start with what we have on the slide and then you want to expand, or do you want to take this slide in its entirety?
I'll let you start with the slide and then I can expand. Thank you.
Okay. And I'm going to give the caveat of there are some medical details here that I am not an expert in, so I welcome corrections or clarification if any of this language is not quite what you understand or how you understand these terms, everyone. But when it comes to end-stage renal disease, what is newly covered is outpatient dialysis services. There has been and continues to be coverage for emergency and inpatient dialysis, so that is still covered as well. Another piece of what is being covered now are immunosuppressant medications after a kidney transplant. And the reason why these additional things have been added is to help people experience some continuity of care for folks who need ongoing dialysis, to make it easier to schedule appointments and to find providers and have those services be available. I do want to point out, though, that as we talk about these additions to CWM, it is still at its core emergency services. So there are going to be things that are not included. For instance, non-emergent medical transportation to dialysis, or the drugs given in conjunction with dialysis are not included. This is actually, of the things we're talking about today, this is the part that is most fully, I believe, in MMIS at this point. It has been fully in the systems for a few months now. And so this can be billed successfully. Courtney, do I have this right? And doesn't have some of the complications that some of the other things we're going to talk about today do.
Yes, Jessica, that is accurate. Outpatient dialysis is functioning in MMIS and providers can bill for this service. I am still working with our team to implement the immunosuppressant medications after transplant. And I do want to recognize too that transplant is not a covered service. Medications after transplant will be covered, and I will be updating providers in our Provider Matters bulletin when we have that medication available for these members.
Thank you. And we will have time at the end for a more in-depth Q&A So if you have questions about any of these particular topics as we go over it, if we don't circle back to it right away, we'll do it at the end of the presentation. Next up, going to talk about behavioral health crisis coverage. And I wanted to start with defining what is a behavioral health crisis. And that is actually, it's defined in rule. So we have the rule here for you if you want to go find that on your own. What it means is there has to be an actual or perceived urgent or emergent situation in which an individual's stability or function is acutely disrupted and there is an immediate need to resolve in order to prevent serious deterioration or referral to a significantly higher level of care or death. So that is the definition written into rule about what constitutes a behavioral health crisis. Now to talk a little bit more about what is covered, this specifically covers crisis counseling and medications that are needed in the short term to stabilize the crisis, and those medications will require prior authorization. When it comes to behavioral health crisis coverage and CWM, there are specific procedure codes to bill. This is the 90839 or 90840. It's also really important to indicate that the claim is an emergency, and this can only be provided by licensed behavioral health care or healthcare providers. And sort of the same conversation we just had about end-stage renal disease, which is this is to stabilize someone short term. It does not include ongoing behavioral health treatment. And so there are limitations. It is expanded, but it is still to cover that crisis specifically. And this is one where, unlike the last topic we covered, there are some pieces I believe that are still being built like pretty much right this moment into our MMIS system. And now I'll turn it over to Courtney for additional info.
Thank you, Jessica. I believe you covered this very well. We are working very diligently to bring this benefit to our CWM members and working very hard to get that functioning in MMIS for billing. So I don't have much more to add. Thank you.
Thank you. And now I have a note about pharmacy because we did talk about medications. We have some directives from our friends at pharmacy, sort of for how to make sure this goes through successfully for the prescribing provider and also for that pharmacy provider. So for the prescribing provider, it's important to write on the prescription if it is prescribed in conjunction with a crisis visit to help connect those dots. It's important to include the diagnosis on the prescription, and it will be required to get a prior authorization. When it comes to the pharmacy provider, there is a pharmacy call center, and I believe I have that phone number directly in the slides later. You're going to need to get, at this point, a one-time override in order for that to go through successfully. And that prescription must be written from the emergency room or as discharged medication from a hospital. So there are, once again, those specific settings and specific providers who are able to do this. I'm going to pause in case there's any additional context here because I know pharmacy can get a little complicated. All right. And then next up, we're going to talk about cancer coverage. So when it comes to cancer treatment, what is covered by CWM? We are working to get treatment of cancer, side effects, comorbid conditions, and other complications of cancer treatment covered if left untreated, it would place the patient's health in serious jeopardy, cause serious impairment to bodily functions, or serious dysfunction to any bodily organ or part. And I'm reading this word for word because it is this is rule language that's really important. Um, you'll notice there's less detail here than on our other sections, and that is because Courtney is hard at work on a lot of these details. This is not yet fully functional in MMIS, and I will pause for Courtney in case there's anything you want to add here.
Thank you, Jessica. You covered it well. Thank you.
We do have some notes about billing cancer treatment. Um, this is for the group 6014, which some of you may be very familiar with as CWM providers. So claims with a cancer diagnosis code from what is currently included in that code group and an emergency indicator or admit type can be submitted, and those can be submitted electronically. If there isn't a diagnosis code from that code group, that 6014, or it lacks those emergency indicators for the additional things like side effects, comorbid conditions, complications, that's when you're going to need a paper claim, and there's going to potentially need to be some more information. So a statement from the provider indicating that it does fit that emergency definition, and this is that same definition we had on that last screen. And this is where we're going to be working with you as providers on making sure that we are correctly qualifying things that are emergency when it comes to cancer. And I know that that's a little less, that's a little wider a net than we've offered on some of these other topics. So I fully expect there might be some additional questions and additional things that will come to light as we continue to get more resources for you. And now I do see a question in the question box that I think directly relates here. So I'm going to read it out loud for you, Courtney, which is, can cancer treatment include things such as chemotherapy, radiation, surgery, stem cell transplant?
Thank you, Jessica, and thank you, Amy, for that question. Chemotherapy, radiation, and surgery would be covered. I will check on stem cell transplant and provide that in our notes when we send that out. The intent of this slide here and the billing explanation, especially under point 2, is to support providers that are providing cancer treatment to our members to bill for what would not typically be considered an emergency with the admit type 1, or on a professional claim, an emergency indicator. So when our patients are seen for side effects, comorbid conditions, complications, and surgery for cancer treatment, to allow those claims to be processed, we would be asking for providers to be submitting a paper claim, not submitting notes unless asked for, but just a provider statement indicating that the treatment is necessary for cancer, because if the person was left untreated, the person's health would be in serious jeopardy. So I hope that this provides the clarification needed regarding cancer treatment.
Thank you so much, Courtney. Now I have a little more about pharmacy related to cancer treatment. And some of these pieces may sound a little repetitive, and they are, but it's also partially because I want to really make it clear what is needed for these different pieces. So when it comes to pharmacy for the prescribing provider, it's important to request a prior authorization for each prescribed drug that is needed and to include that cancer diagnosis on the prescription. And then I note that for some drugs, we may require chart notes to show that those clinical requirements are met. So that's part of the prior authorization process for some drugs. And I believe that there are some resources we can get to you for more details on where that might be. And so because we've been talking about, new types of coverage and that new addition of pharmacy coverage, um, sort of repeating what we know about prescriptions and CWM at this point in time, which is that, and this is sort of from a lens of from pharmacy directly. If a prescription is for a non-covered condition, then pharmacy should notify the patient that the drug is not covered by their Medicaid plan. If it's a prescription for a covered condition or the diagnosis is unknown, then the pharmacy should work with the provider on that prior authorization pathway. And if a prescription is for a behavioral health drug prescribed as part of an emergency visit or in conjunction with a crisis episode, that's when using those behavioral health codes and calling the Oregon Pharmacy Call Center for that override is an important step. And that I knew I had the number on one of these slides. So that number is 888-202-2126. And now we've been talking about prior authorizations. So just a quick note about different ways that providers can submit PA, prior authorization requests. There is that Oregon Pharmacy Call Center number that I just gave. There is, with the exception of some of those items where we said we needed that paperwork as opposed to online, there's the provider web portal. And then we do have a fax number at 888-346-0178. And we do have a fax cover sheet for you to use if you are faxing. And just to reiterate, all prior authorization requests should document the diagnosis and when it comes to behavioral health conditions, that recent crisis or emergency visit. For some drugs with clinical prior authorization criteria, chart notes are required, and here's that website I alluded to earlier. There is a pharmacy-specific website to learn more about the pharmacy aspects of those drugs and to look at those specific criteria. I want to pause and see if there's anything related to what we've talked about so far that we want to make sure we circle back to. And Courtney, I do see a note about, like the difference between screening versus cancer treatment. Do you mind talking about that a little bit?
Yes, thank you, Jessica. The CWM benefit does not provide screening for cancer. There are some cancer screening services through public health. When a CWM member has found that they have cancer, they will be referred to a specialist. So the kind of a typical process for um, obtaining a treatment specialist would still be in place here.
Thank you so much. Oh, and I am seeing a few folks asking about if we're going to have this webinar available, and just to let you know, it's being recorded right now, and we're committed to making sure we send you a follow-up packet of information. So this information that you're seeing in the slide deck itself, as well as a few other resources. So expect that within the next 2 weeks if you are listening to this live. And if you are listening to this as a recording, then I'm going to make sure for any of the folks in our community partner network that this information is also widely available on our group site website. So thanks. Quick plug in the middle of this presentation. And I'll use that to transition us to talk a little bit about those. We talked about how some of these pieces are already built into our systems, and there's been a lot of hard work on that. And there are still some pieces that are coming. And so this particular information is grabbed directly from a Provider Matters newsletter recently, but it's important enough that I'm going to say it out loud to you here, which is that we are working to update the provider web portal so that all of this is included. But while that work is still underway, there are some things to know about submitting bills, which is you have a choice to either wait to bill OHA until after we fully update all these emergency codes, which I think is in early July. You can also bill for these services now, knowing that the claims will be initially denied and then reprocessed. And then I'm repeating because these codes are also important. When it comes to behavioral health crisis treatment, there are specific procedure codes, which is the 90839 or 90840 to bill if it is through CWM for behavioral health crisis treatment. And now the official route for information, if you have a specific situation that you want to work with provider services to make sure that we all have a shared understanding of if it is covered or not, how it should be billed, then there's the provider services 1-800 line here. And then if you are not a provider, because I do believe some of our folks are interested community partners who maybe don't have that provider hat to wear in those tools, there's also the member route of contacting client services about any questions around billing or covered services, things like that. And so we have the client services number here too as a resource for you all. I mentioned that that particular slide content came from Provider Matters, and it's a great resource for providers, and I highly recommend it. When we send this along, we'll make sure that you have this link as well, which is you can see all past editions, or at least all the most recent past editions of the Provider Matters newsletter, as well as sign up and get future emails. Very talented colleagues spend a lot of time working on getting providers information as we learn it or as we make it at the state. And so there is a specific resource for ongoing updates and information about all of these changes. So I would say that I will do my best to get out to my network as much information as I can, but you can get it straight from the horse's mouth, so to speak, via our Provider Matters newsletter. And now we're going to transition into talking about what is an emergency. Now, this is a lot, and it's in rule language, but I'm going to read it out loud once, and then I'm going to talk a little bit about the pieces that we've bolded here and what that means. So don't mind me. Thank you for your patience as I read the legalese, and then we're going to talk about what it means. So an emergency medical condition means a medical condition manifesting itself by acute symptoms of sufficient severity, including severe pain, such that a prudent layperson who possesses an average knowledge of health and medicine could reasonably expect the absence of immediate medical attention to result in placing the health of the individual, or with respect to a pregnant person, the health of the person or their unborn child, in serious jeopardy, serious impairment to bodily functions, or serious dysfunction of any bodily organ or part. An emergency medical condition is determined based on the presenting symptoms, not the final diagnosis, as perceived by a prudent layperson rather than a healthcare professional, and includes cases in which the absence of immediate medical attention would not in fact have had the adverse results described in the previous sentence. So that was a lot. And for some of you who have worked with CWM in the past, you will know that this emergency definition is a wider definition of emergency than has historically been applied to CWM in the state of Oregon. What this means is that with our new emergency definition, instead of relying on what a healthcare professional has as their final diagnosis, we instead can use what is called the prudent layperson, which means an average human who is not a doctor, who does not have a deep knowledge of medicine. Um, this is your Joe Schmo, like myself, who struggled, frankly, with some of the medical jargon I have said to you today. That it is okay for something to not ultimately be considered serious impairment to life, limb. Um, it can just be something that appears at onset to meet what could be one of those definitions. And so that's why I've bolded, the prudent layperson part, having average knowledge of health and medicine. It's important that it relies on the absence of getting attention could cause these problems. And there we get back to that serious jeopardy, serious impairment to bodily functions, or serious dysfunction of any bodily organ or part. And that it's based on presenting symptoms. And I'm really hammering this in, so I apologize for saying the same words over and over again. But it's a pretty big change for us. And this change is officially happening July 1 of this year, so in a few days. We're switching to this new emergency definition. It is written into our rules, and there's been a lot of work to transition a system that was focused mostly on those final diagnosis codes and the determination of medical professionals into a system where we can use admit diagnosis codes instead. And so there's been a lot of updates to code group 6014. And this is the part where I'm going to stop talking. I'm going to go to the next slide, and Courtney's going to walk us through an example to sort of put it into real context.
Thank you, Jessica. So with the expanded emergency definition that will start on July 1st, a individual experiencing chest pain may arrive at the emergency room with CWM coverage. On admit diagnosis of chest pain, which is in group 6014, the person would have this claim covered, even if the final diagnosis was acid reflux, which is not in group 6014. So this is a good contextual example on how CWM emergency benefits will be changing that emergency definition to allow for a person to use their emergency coverage, believing that their health is in jeopardy on admit diagnosis, even if the final diagnosis is not found in that group 6014. The group 6014, just to kind of remind providers, is a code group of conditions that are always considered an emergency. I'll turn this back over to you, Jessica.
Thank you. And I do want to pause for a second to see. I'm just going to take a quick look at the question box. And it looks like some of these expansions, and I think in some ways we might be kind of breaking the news about this new emergency example. I'm not sure. I know it went into rule, and if you were interested in reading complicated rule notes, you might have seen hints of this. But this is pretty new information. Is that correct, Courtney?
For the expanded emergency services, yes. And again, I understand the complicated rule policy. There was a temporary order filed at the beginning of this year for the expanded emergency for services for outpatient dialysis, behavioral health, and cancer treatment. I don't know. There was a question from Melody about whether or not that was included in provider matters, and unfortunately I wasn't working with the agency at that time, so I can't speak to whether or not that was posted in provider matters in January. But I know that moving forward, I will be using Provider Matters to share any updates for the CWM program.
Mhm. And I'm fairly certain Provider Matters had, although there are a lot of updates that go into Provider Matters, so it might have been buried towards the bottom under Medicaid updates in January. Um, but as we've been hard at work updating the systems to, fully meet the requirements of the rule, I'm excited that we're finally able to share it more widely, including here, which is something I'm still very excited about. And I also want to sort of enlist your help as our audience in helping get the word out about these changes, especially the changes that have already happened and already functional in our system. To quickly go off script and hop on a soapbox, this is something that a lot of providers, I think, aren't aware of, and a lot of members certainly aren't aware of, and we can help build this shared understanding. And this webinar today is just one of those pieces that we're trying to put in place. So would love to hear from the network too, and happy to work offline about ways in which we can get the word out about these changes and really build something together. I'm going to hop off the soapbox and continue our presentation, but really thank you everyone for your questions and comments, and please keep them coming. Now this next piece is sort of another slight left turn from what we've been talking about, but it's another piece that is really important, and it is around helping people understand when something is covered and when something isn't, and they may need to pay. So another change that is coming very soon is that when it comes to CWM members, in the past, it was recommended to complete the 3165 form, which is that form that talks about providing a non-covered service where the provider and the member both attest to understanding what is and isn't covered and what that's going to mean for them when it comes to bills. So this was required for OHP plus, anyone on full OHP. It is now moving forward required for CWM members as well. And we're going to talk about the 3165 form, but just know there's also a 3166 form for pharmacy services, and these rules technically also apply to the 4109 document, which is a document for planned community birth services. So I would expect it should not come up for CWM because anyone who would be filling out that form should be on CWM Plus. But do want to talk more in the context of the 3165 specifically. So the OHP client agreement to pay form is one that must be completed by providers before billing any OHP or CWM member, and it must be kept on file. If that 3165 form is not completed or can't be found, then providers cannot bill the member. I recognize that at this time, with a lot of changes to CWM, for example, there's going to be some questions about like what is and isn't covered and how to best fill out this form within that context. So I do want to offer, at least for the short term, there is always provider services to help walk through any specific situation that you may find yourself in and figuring out what exactly is or isn't covered and how to make sure that we are really doing our due diligence and not billing people for things, in the cancer, behavioral health crisis, and stage renal disease arenas that maybe in the past weren't covered and now are. We're not going to go in detail through the form today, but I did want to pop it up on the screen so you can see it. You can find it in our form server by searching 3165. It does include pieces specifically about provider responsibilities and steps as well as client responsibilities. And I do see a note in here about people who are afraid of forms that talk about agree to pay. And I have to say, I went through some of the same thinking about this change where it was recommended versus is required. Um, but it is very important because it is a way to help protect people and to make sure that we are being transparent about what does cost money and what doesn't and what people should expect, because medical bankruptcy is still unfortunately a very real thing in our country, and this is required, and it really does create that transparency. I'm on a soapbox again, but I'd love to learn more about the situations in which people don't feel comfortable with this form and ways in which we might be able to better get awareness and education out. And in fact, part of that, which is currently underway, is that we are making sure that all of these forms will soon be available in the 10 major languages represented by the CALM population. So in addition to English, Spanish, Russian, Vietnamese, Somali, Arabic, Korean, simplified and traditional Chinese, and Romanian. So that is one of the efforts underway to really make sure that people are understanding the forms that they have in front of them, and it is available in a language that they understand and feel comfortable with. And I know we have some specific questions in here about what is and isn't required. And I definitely don't have those answers without going back to the subject matter experts. I'm wondering, Courtney, if there are any pieces in the question box we can answer right away, or if we should just bring them back and get you all answers when we have time to really dig into it.
Thank you, Jessica. I'm try to keep up and answer the ones that that I can. I think it will be helpful for me to be able to give some thought to some of these good questions and answer those later.
Thank you so much. So I want to let you know we're not ignoring your questions. We just want to make sure we get good answers and that we work with you on some of those. I do see one question about if there's information about charity care programs on this form. And I do know that on page 2 of the form, it talks about charity care. I don't think it provides specific like referral information because that is different across the state, but I do know that that is one of the items that is on the checklist of other resources that clients may be able to access. So it's called out, perhaps not in its complete way. And I think this also goes back to the really important role that our community partners and our providers play in being that human link. As long as we have processes and rules and codes, we need humans too to help make sure that people have a way to understand what's happening and what their options are. And I don't think we're ever going to be able to make a form that replaces the need for folks like you all, but we can keep trying. And I do want to clarify that I'm just going to go back to the form for a sec. This is for items that are not covered by their coverage. So for a CWM member, you would only put on here items that are not part of CWM covered services. When it comes to OHP Plus, it would only be things that are not covered under OHP Plus. So that might be different depending on what coverage someone has. If someone has supplemental benefits for pregnancy, there are things that are covered that aren't for adults in general. So this is going to be a different set of things you would put on here depending on the individual you're treating, what kind of provider you are, and what kind of coverage they have. All right, now I got to my promised one slide on Healthier Oregon because I think it is really important to talk about CWM. These changes are happening that I've talked about today. These are all separate from Healthier Oregon, but Healthier Oregon is also a program that is starting July 1. There's a lot of things starting July 1. And so that means that moving forward, we shouldn't see anyone in CWM who is between the ages of 19 and 25 or 55 and older, because the Healthier Oregon program is going to automatically move those CWM folks in those age groups over to full OHP benefits, and that's going to happen automatically July 1. This also means that anyone who is newly applying and they are in those same age groups, that's 19 to 25 or 55 and older, if they apply on July 2nd and they're eligible by all the other metrics other than immigration status, then they would not spend any time on CWM. They will go directly to full OHP, OHP plus benefits. And so that means that when we talk about our definition of CWM, then we're really talking not about adults, but we're talking about adults ages 26 to 54 who may be on CWM or CWM plus. Anyone else, by our laws, as is currently on the books and starting July 1, will be on OHP plus. So I did want to call that out. Right now it's June 17th, so this isn't yet in effect, but it's very, very soon. And we have other resources, and I'm very happy to talk at length about Healthier Oregon with any of you, but not for today's topic. So if you want to learn anything about Healthier Oregon or want to talk through any concerns, any questions you have, please, please, please work with me. I'm happy to talk to you. This is a priority program. All of this is separate from the changes we talked about today. It's just very confusing because a lot of things are all happening at once. And I feel that. I see a few questions about Healthier Oregon in the chat. So I will mull over those while we finish up our last couple slides. We do have a few CALM-related resources that are ready right now, in addition to the Provider Matters newsletter I talked about earlier. There's the full code list available that continues to be updated. There's a policy page for CALM. And I'm going to stop talking and let Courtney talk a little bit more about what's coming soon, because I think this is your project and something that you've been working hard on.
Thank you, Jessica. I was trying to answer as many questions as I could in the chat here. The CALM benefit will have a web page, which I'm really excited about, providing as much resource and transparency as possible for members and providers to understand what benefits are covered, how to bill, how to appeal, and to support members with accessing the care available to them. Continuing to review and update the CALM Emergency Diagnosis Code Group to include cancer and behavioral health treatment, and that code group is reviewed on a quarterly basis to include other conditions that could be emergencies. So we do look at utilization and really do our best to include as many emergency conditions as possible in that group to support our members with the coverage that they need. I think I'm kind of try to get as many of your questions answered as possible in the chat here.
Thank you. And in fact, our next slide is for questions. So we might pause for a sec while we look through these. Please continue to put in any questions, anything that came up. I know there are some CALM Plus specific questions, so I might follow up offline since that's not the topic we're on today. I am seeing there's some things about when, like how Healthier Oregon transitions into CALM, and I'm going to call that provisionally on topic because it is it's getting to the point where we're not going to be able to talk about Healthier Oregon without talking about CALM and vice versa. And this is the part where I'm going to say something and Courtney is going to make sure I'm saying something correct. We'll see how this goes. My understanding is that we were able to build into the Healthier Oregon program A protected extra year of full OHP benefits for people who are turning 26 in this first year of Healthier Oregon. So if I am on CWM today and I am 25, but I am turning 26 July 15th, on July 1, I would transition from CWM to Healthier Oregon. And then when I turn 26, I get to keep my Healthier Oregon for my next year of eligibility instead of immediately reverting to CWM. I also saw some questions about, like what's happening in the future and what about ages 26 through 54? And that is largely up to legislators. I don't know. I can't say a lot about it, but what I can say is that right now the bill as it is designed removes that limitation after the first year and then needs to be funded in order to expand to all age groups. And if you are in a position where you can advocate, you are welcome to do so. Putting my state hat on right now, I'm giving you factual information because that's what I'm allowed to do. And I hope that information is helpful. And just know that some of these items, I believe we will have a FAQ coming out very soon about Healthier Oregon that's going to talk about some of these in a little more detail. It just needs to go through some final steps. So I said I wasn't going to talk about Healthier Oregon, and it turns out I can't not talk about Healthier Oregon. So I hope that other slightly more information is helpful to you all. And more questions have popped up while I was talking about that. I do see a question about that, the responsibility to pay forms and, being in English versus another language. And I think from OHA's standpoint, we're working on making sure we are providing more languages. And I would say it's important to have a version that the provider can understand and have a version that the client can understand. So that might mean manually adding in English side by side with the other languages. And those forms should match exactly so that the fields should match if you're looking from one document to the next. I see a question about that. So the medical application, how to fill it out for someone who doesn't have an immigration status. And I would say the application itself so it'll ask if someone is a US citizen or not. If they're not a US citizen, it'll ask about, does someone have one of these specific immigration statuses? If the answer is no, then it's not going to ask for additional immigration information, and that is completing it in its entirety. We answer the questions to the best of our abilities, and if someone is eligible by, income, household, residency requirements, then that's when we would expect them, if they're in a non-covered age group in that 26 to 54-year-old range, that's when we would expect them to get CWM or CWM Plus instead of OHP full benefits. And if you have more questions about filling out the application, the OHP application specifically, when it comes to folks who are non-citizens, I highly recommend talking it through with your regional outreach coordinator, because they're going to be your best resource on how to navigate some of our more complicated pieces to the OHP form itself. But just know that it has been built to attempt to be as neutral as possible when it comes to someone who does not have an immigration status, who does not have documentation. Let's see, Courtney, are there any other questions that you answered in chat that you think we want to make sure we are saying out loud for the recording purposes?
I can't think of any offhand. I think there's quite a bit about the kind of ending age for HOP and that transition. And Your explanation about the uh, kind of what's going to happen this year is, from my understanding, also true moving forward. So an individual's eligibility period, um, if they are turning 26, there is not going to be a hard stop of HOP benefits on that birthday or in that birth month. The eligibility period will sort of run its course for that uh, annual period. So if a person signs up late in their 25th year, they will have barring any income or other households changes,
Mhm,
they would have their eligibility period through that year. So that
mhm,
will be true moving forward as well. And HOP members will have a benefit package identifier of BMH. So in the HOP members will not be distinguishable from benefit package identifiers from other OHP members, which was by design.
mhm. I think they have unique perk codes, but the benefit package will look exactly like anyone else on OHP Plus, right?
Yes, that's right.
I am glad we added in a little bit of Healthier Oregon into this, although I do want to circle back and see if anyone had any questions that they wanted us to dig into more when it came to the CWM changes. I do know we have a few very specific ones that we will bring back to our subject matter experts. I do have a question here, Courtney, maybe you can answer. When it comes to CWM, is urgent care considered a setting where people can be covered?
I want to take that question back just to make sure that I answer that correctly. It was one that I had written down. It was a
Okay,
good
excellent.
question. Thank you.
Oh, and also someone asked a question, but I wanna take a moment to double down on this and say it out loud, which is talking about interpreter services. Yes, interpreter services. If something is a covered CALM service, then interpreter service alongside is absolutely covered. And not only is it covered, it's required for us as providers who are billing Medicaid to meet people's language access needs. And so, absolutely, interpreter service, I just want to say it over and over again. Yes, get interpreter services. It is covered. For fee for service, you can bill us for it. Um, if anyone has any questions about interpreter service or is struggling with language access pieces, I want to help and I want to learn more. So please do not be shy about that. We will find solutions. And it's really important. And I'm actually wondering I'm going to say this, I'm not going to answer the questions today, but if anyone wants to dump any Healthier Oregon questions into the chat, I want to get you those answers soon. So this is not the day for it, or at least not in this presentation, but I'd love to build more content for you on that. And so if this is actually not only Healthier Oregon, I'm just thinking that that's one of the topics that is probably on a lot of minds right now, and there are a lot of open questions from a provider point of view. But are there any things that you want us to cover when we come back and do more of these collaboratives? Are there any topics that you all as providers, as community partners, have struggled with in the provider arena or want to learn more about? This is your go ahead to put absolutely anything in the chat box, in the question box, and I'm going to take that back to make future content. I'm going to check and see if some of these relate to our talk today, and I may talk about it, but I also like, if it means that in the next couple weeks I'm building a specific Healthier Oregon webinar for us providers, like I'm committed to doing that. And I want to make sure that that happens in a setting where that's what we're focused on, it's not an afterthought to another presentation. I want to make sure we give it due diligence. And that also applies if there are any things you want to learn about CALM Plus. Oh, I do see a question that is specific to what I was just talking to. So if someone needs interpreter services, as long as they are fitting into that definition of an emergency as we covered, the one that is starting July 1. So it doesn't necessarily mean that the final diagnosis needs to be an emergency code. As long as the admit code is on the covered list, then yes, interpreter services absolutely will be covered. And I see there's a lot of questions about exactly how Healthier Oregon age bands work, how exactly people are going into CCOs or not. And I want to, yeah, we'll circle back and we will get you those resources. And in fact, we gave a general Healthier Oregon presentation. Ooh, I want to say it was at the end of last month. So I will send you the link to that because some of these questions are in there too. Someone's asking, does Calum Plus cover interpreter services? Yes, it does. In fact, I will go out on a limb and say I think any Medicaid, any OHP benefit package covers interpreter services. I don't know much about QMB, so I'd have to circle back on that. But I know for sure Calum Plus, OHP Plus, OHP for children, OHP for folks with who are over 65 or who are considered permanently disabled. All of those packages absolutely cover interpreter services. And if you are hearing otherwise from anyone, please let me know because that's something that we really want to tackle. And if people have questions about QMBs and Medicare savings programs, we can circle back and have content about that in the future, or that non-Magi side of things. OSIP-M. I'm just throwing out stuff to see if there might be some topics that are resonating with you all. I hear you loud and clear that Healthier Oregon is definitely one to spend more time and energy on. Maybe get you all the perk codes and other resources like that. If you have any questions about pharmacy. Thank you all for hanging on as I awkwardly pause because I want to give folks room and space and time to put their thoughts down. All right, OHA folks, is there anything at all that we want to make sure we say before we wrap up this presentation?
Nothing from the pharmacy team that's quietly listening in the distance.
Thank you so much for being here. I see there's still a few folks putting things into the question box, and I invite you to keep doing that. I'm gonna hop over to our thank you slide. I want to thank you all for coming here today. I know I grabbed 2 hours and I'm using closer to the 1 hour, but I wanted to make sure we had time to talk about anything that came up. And so thank you so much. I also want to thank Courtney for all the hard work getting this information that I think for many of us this might be the first place that some of this information has been available to you. And also, once we have this recorded and up on the air, I'm going to share it out, and you are welcome to share it with your colleagues and with other providers who you're working with. And really happy to put together more content in any direction where people need it. And so the best way for us to know what to put our time and energy in is to hear from you all, which is why I am harping on wanting you to talk to me and to let me know where your questions are, what your concerns are. It doesn't have to be in a giant group like this. Happy to work with any of you one-on-one. And to convene, as you saw today, we had some folks quietly available in case we needed them, and we have many other awesome folks at OHA who we just need to know when they're needed, and we will work on convening the right resources for you all. And I would say for anyone who has any questions about Healthier Oregon, as step one, if you are one of our community partners, you have access to group site, there's a lot of great information there. And so, like, don't wait for us to grab the whole packet of information for you. There's a lot of information about Healthier Oregon, and we're making more every day. If you aren't sure where to find resources, feel free to hit me up via email or otherwise reach out to me or any of your regional outreach coordinators, because they also, we've all been working hard to build something and learn about it all at the same time. And I'm sure we'll be learning more and sharing more even after July 1. But whether it's these CWM changes as they come fully into effect, Healthier Oregon, we'll probably circle back and talk about end of public health emergency, but we have some time for that. We're really excited to engage with you, however is going to work best for you all. And as a closing remark, I do want to say the Provider Collaborative went away for a few months while things got pretty hectic over here in OHA land, but we're back, and I'm excited to be back and to be talking directly to you all. And so we're going to continue to line up content. And I get the feeling we might actually want to do something sooner than quarterly when it comes to getting you more Healthier Oregon information. So look for that to come out. Maybe I'm going to try to put together something for you, maybe even next month, because I think it is important to get that information out. And with that, I think I need to stop stalling. We got a lot of good stuff in the chat, and thank you all, everyone who put anything in there. I will review it again once we close this all down. And in the next 2 weeks, expect a more complete packet that has these slides, other information, hopefully a memo, and I'll sneak some Healthier Oregon information in there as well so that you have that all at your fingertips. Thank you so much. Have a great day. Have a great weekend. Have a great Juneteenth, because that's coming up soon. And we'll continue to be in touch. And thank you, Courtney. And thank you, people whose names we didn't say because they were quietly helping us on the back end.